Tonight, we are here for the 7th installment in a series of biannual public lecture that we call This is Public Health. These lectures are for us to learn and think critically about a public health issue people are faced with locally and globally. Public health crosses multiple fields of study such as health, social and human sciences to touch every aspect of our lives on a daily basis. It aims to prevent injury and illness, protect health, promote wellness for people in all communities and of all ages. This ties in well with that of what we will be focusing on tonight. A pandemic is the spread of an infectious disease across a large region. You may recall the term from 2009 when the H1N1 influenza pandemic, otherwise known as the swine flu, reached more than 200 countries, including Canada. But this was not the first time we had faced a pandemic. In 2018 is the 100th anniversary of the 1918 influenza pandemic. It infected a third of the world's population and left approximately 50 million dead in its wake. If you look at 50 million, the population of Australia in its entirety is about 25 million. It's twice as the number. It was one of the deadliest disease outbreaks in recorded history. Tonight, our speaker will discuss the 1918 pandemic and the H1N1 virus and explain the important role that public health plays in preparing for and responding to emerging pathogens. It is my pleasure to introduce our speaker and our distinguished scholar, Dr. Stephanie Yanow. Dr. Yanow is an associate professor in the School of Public Health. She worked in the Provincial Laboratory for Public Health during the H1N1 crisis and saw its response firsthand. Her research is focused on different aspects of malaria, from basic pathogenesis to the development of diagnostics and vaccines. Dr. Yanow understands emerging and resistant pathogens and the risk they pose in a global context. Her work in malaria-affected countries may provide knowledge and capacity to respond to pathogens that may threaten Canadians in the future. Please join me in welcoming Dr. Stephanie Yanow.
So thank you very much, Dean Johnson, and thank you all very much for coming to this lecture today. So this year marks the centenary of one of the worst pandemics in our modern history. And today we're going to take a look back at the pandemic of 1918, looking through a historical lens, and consider the many ways that this pandemic shaped our understanding and our approaches to public health. So a pandemic can be caused by a number of different kinds of pathogens. Some of you may be familiar with bacteria that cause cholera pandemics, but also a major concern are viruses. So as an example here, HIV is a virus that caused a pandemic in the 20th century and that continues today. And today we'll be talking about the causative virus for the flu, which is the influenza virus. Now, one of the important differences of a virus compared to a bacteria is that a virus needs to infect one of our cells in order to be able to replicate and to be infectious. And the way it does that is through these proteins here that are found on the surface of the virus. So deep inside the virus, we have the genetic information of the virus. This is encoded in RNA. But on the surface, we have these two proteins called hemagglutinin and neuraminidase. And both of these proteins are critical for the virus to attach to our cells and then to be able to replicate and continue to transmit disease. Now, these two proteins come in different flavors or subtypes. So we have 16 different H types for the hemagglutinin, and we have 9 different N types for the neuraminidase. So when we talk about flu viruses, we talk about which subtype of the H and the N are combined together on that particular virus. And today we'll be talking mostly about H1N1, so that's subtype 1 of the hemagglutinin, combined with subtype 1 of the neuraminidase. But this virus can be very cheeky. It can mix and match these H and N types to create entirely new viruses. And this is why every year, when you get your seasonal flu shot, that vaccine always contains a slightly different mixture of viruses. So depending on which subtypes are circulating and also some of the more subtle changes that the virus undergoes from one year to the next. Now these viruses, the seasonal flu viruses, are very different from the pandemic viruses, particularly the kind we saw in 1918. In 1918, humans were exposed to a completely new virus with a new H type and a new N type that we'd never been exposed to before. And because of that, we had no pre-existing immunity to be able to fight off this virus. As a result, the death toll was tremendous. So as Dr. Johnson said, about 500 million people, or a third of the world's population, were infected from the pandemic of 1918 and 1919, and about 50 million people died. So about 3 to 5% of the world's population at that time. And we can see that the pandemic had a direct impact on our demographics. So here we're looking at data from the United States at life expectancy over the course of the 20th century. And what you see is that in 1900, it was just under 50 years of age. The life expectancy rose steadily during the 20th century over about 80 years. But look here at this trough. Here, the life expectancy dropped by about 10 to 12 years. This is directly attributed to the 1918 pandemic, and it caused a more pronounced effect than either World War I or World War II. Now, 100 years later, we still don't know where this virus came from. Many of you may have heard of it as the Spanish flu, and the one thing we do know is that it didn't come from Spain. So Spain was actually one of the first countries to report cases and deaths from the flu in 1918, and that was largely due to the fact that Spain was a neutral country in World War I, so they didn't have any media censorship. Whereas in neighboring France and in the UK, where they also had cases emerging, that information was actually being censored for fear that it would negatively impact the morale of the troops or possibly even give the enemy an advantage. So now we know that this virus was likely circulating on the battlefields of World War I, probably as early as 1916. Now, it may not have been in the same form of the virus. It might have been a precursor virus that was still evolving and adapting for humans. And we believe that this virus actually originated in wild waterfowl, so birds, and crossed that species barrier to infect humans. Now, once this virus gained a foothold in the human population, it spread very quickly in 1918 and 1919 along 3 waves. And you can see the waves here in this very old data from the time where we're looking at the death rate in New York, London, Paris, and Berlin during this period of the pandemic. And we see the first wave is just this small hump here in the spring of 1918. And actually, some of the earliest cases were reported at a military camp in Kansas in March of 1918. Now, this first wave caused many infections, but it didn't have a very high mortality rate. It was only in the fall of 1918 when this second wave came through that we really saw that peak of mortality that we associate with the pandemic, and we see that in all of these cities. Now, this lasted from about end of August to November, December of 1918. The wave then subsided, and it was followed by a third wave in the winter of 1919, where again, many people were infected, but by now few people had died because they had developed some immunity to this virus. Okay. Now, we can already tell by the timing of these waves that this was not our typical seasonal influenza, which causes sickness in the wintertime, right? The first wave is in the spring, and then the major wave starts at the end of summer. But there are many other features of this virus that are also very unusual, particularly the unprecedented morbidity, so the sheer number of people who got sick, how sick they became, and how many people died. Now, we don't know why this virus caused such a high rate of mortality, but we do know that most of the people who died of the flu had pneumonia. So they died with bacterial infections in their lungs. And so what they think is that the virus came in and damaged the lungs, and this created the ideal context for an opportunistic bacteria to then come in and finish the job. And remember, this is in the era before the discovery of antibiotics, so there was really no way to treat these secondary bacterial infections. Another really unusual feature of the 1918 flu was the age of the people who died. And in particular, half of the deaths from the 1918 flu were in young adults, aged 20 to 40 years. And that's shown on this curve here. Now, before I get to the W curve, I'm just going to point out first the U curve. So here we're looking at the death rate in different age groups. And what we typically see with seasonal influenza is depicted by this dotted line, which is the U curve. So we see the very young and the elderly are at greatest risk of death. But what we saw in 1918 was this W curve, so this peak of mortality in this age group from 20 to 40 years old. And we still don't know why this age group was so susceptible to this virus. But there is some very interesting data from scientists in Eastern Canada that proposes there may be a link to the Russian flu that swept through Canada and Europe in 1890. So some demographers from universities in Ontario and in Quebec looked a little bit more carefully at the peak age of mortality in this age group. And here they're looking at the deaths from the flu in Ontario in red and deaths from the flu in other locations in the United States. So these are flu-specific deaths, whereas these are all-cause mortality, so cancer and so on. And when they looked more carefully at those who died from the flu, they found that actually there was a peak of mortality in people aged around 28 years. And if you look 28 years before that, that coincides with this Russian flu that swept through. So what they've proposed is that perhaps these people had been exposed to the Russian flu either in utero or as in early childhood, and perhaps this altered their immune system in a way that meant they could not launch an immune response when they were faced with the flu in 1918. But of course, we still don't know if that's the case, and this remains one of the key enigmas of the 1918 flu. Now, another important aspect of the flu is how quickly it was transmitted around the world. This may be due to the virus itself. It was inherently a highly transmissible virus, and that's represented by this R0 value, or reproduction number. What this number means is that for every person who's infected with the virus, how many others exposed to that person are then likely to become infected. And for the 1918 flu, this number is as high as 2.4. So if I were infected, probably about 2 or even 2 to 3 people would be infected as a result of being exposed by me. And this is quite high for an influenza virus. Typically with the seasonal flu, the R0 value is around 1.2. But we know that the context of the war was critical for the massive and rapid spread of this pandemic. So you had these trenches, you had soldiers who were sick with other infections, who were exhausted, you had very crowded military camps, you had boats bringing new soldiers in and bringing sick soldiers back. And then at the end of the war, you had this massive mobilization of troops as they were returning home, again on these crowded ships, and many of them were carrying the virus. Now this map here just shows you the global spread of this virus. So in red, you can see the arrow showing where the flu spread after the first wave, and in blue is the spread after the second wave. So what you see is that it's really all over the map. So you have the virus going back and forth between the training camps in North America and the battlefields of Europe. But you also have the flu going into southern Africa. It was very quickly spread up the railway. It then goes over to India and even reaches as far as New Zealand and Australia. And then, of course, after the war, 100 years on Sunday, there were massive celebrations worldwide to mark Armistice Day. And this is a picture from London celebrating the end of the war. And you can see the crowds of people here. This really creates the ideal conditions for a highly infectious virus to spread. So what was the public health response at that time? Well, they recognized that these kinds of massive public events were just helping to contribute to the spread of this disease. So several measures were put in place to limit public exposure. This included canceling parades to celebrate the end of the war, closing schools, dance halls, and movie theaters. And in general, the public was fairly accepting of these restrictions. And this was probably a result of having just gone through 4 years of curfews and rations and this celebration and nationalism at the end of the war in light of the victories, and a respect for authority in terms of deciding what was best for the public. But there were also some important public health responses that were based on the scientific understanding of the day, and particularly the theories of germ theory. So germ theory was put forward by Louis Pasteur and other scientists in the 1800s to explain how disease can spread. So before this, there were ideas about a flu being caused by something in the air, something that smelled bad, or something related to sanitation, for example. But those scientists demonstrated that actually they're pathogens that are being transmitted from one person to another, or through water and so on, and those were the causative agents of disease. Now, back in 1918, viruses hadn't been discovered. So they didn't know about viruses per se. They knew about bacteria, and they knew how bacteria could be transmitted. So in light of this, many of the public health responses were really geared towards limiting that person-to-person transmission of whatever this pathogen was. So that included having good ventilation, promoting hand washing to make sure people didn't spread the virus from person to person. And these public health measures were implemented in many jurisdictions with relative success, but sadly there were some examples where they were completely ignored. And the example I want to share with you is from Western Samoa in the South Pacific. So really as far removed as you can imagine from the battlefields of World War I. So the Samoan Islands were divided into Western Samoa, which was governed by New Zealand, and American Samoa. And in the time of 1918, Western Samoa was highly dependent on New Zealand providing cargo and supplies to the islands. These are very, very remote islands. So you had these cargo ships like the SS Toulon that's shown here that would go on these cargo runs, and they would deliver supplies and move goods around the islands. Now, in 1918, in November, this boat was meant to set sail from Auckland to start one of these cargo runs. But even when it set sail, there were already some of the crew were sick with the flu. Nevertheless, it went on started its route. Its first stop was in Fiji, and there it unloaded cargo, and it brought on 90 cargo workers from Fiji that went on to help with the rest of the route. By the time the Toulon arrived in Apia in Western Samoa just a few weeks later, nearly the entire crew were sick with the flu. And here's where the fatal mistake was made. They allowed the crew to disembark from this ship and seek medical attention in the islands. And this brought the flu to this remote part of the world that had never had any exposure to the flu before. And by the end of December, 22% of the Samoan population was dead from the flu. This was such a grave error that the Prime Minister of New Zealand flew to Apia in 2002 to issue a formal apology on behalf of the nation. Meanwhile, just 60 kilometers away in American Samoa was one of the greatest success stories from the 1918 flu. So here, the American governor had been following on the radio all the reports of the public health measures that were being introduced at home and around the world, and he knew what was happening in Western Samoa, and of his own directive, he instituted a very strict quarantine for his islands. This meant that any ship that wanted to have people disembark had to first be quarantined to make sure that nobody was sick with the flu. He also engaged local islanders to patrol the beaches and make sure that no smaller boats were trying to illegally disembark. And it was said that he even fumigated and heat treated the mail to make sure that these pathogens were not getting into these islands. And by the end of the pandemic, American Samoa was one of the very few countries in the whole world that didn't have a single death from the flu. So what about here at home? So Canada was hit very badly by the flu. We had 50,000 deaths, again, more so than perished in World War I. And most of these deaths occurred during the second wave of the flu. And that second wave came into Canada from the United States. And it can actually trace back several events that occurred at the beginning of September in 1918, where the flu came into our country. Some of those events included the movement of a troop of Polish soldiers from a training camp in the United States up to Niagara-on-the-Lake. Another one was a ship that left Boston carrying soldiers en route to France, but so many of the soldiers were sick that they had to call into port in Nova Scotia. And another one was the Catholic Church hosted a Eucharistic Congress just outside of Montreal that had 25,000 participants, many of them from the United States and many of them carrying the flu. So within a matter of weeks, there was an outbreak. This led to an epidemic, and then very quickly the flu spread west. And this was largely facilitated by the Canadian Siberian Expeditionary Forces. These were troops that were actually on a covert mission to go and support the Allies on the Eastern Front in Russia. But to get there, they took the railway from Eastern Canada, which had this outbreak of the flu, and they traveled all across the country, basically bringing the flu at every stop along the railway. So Canada very quickly had its own pandemic on its hands, and because of the war, there was a severe shortage of doctors to tend to the sick. And that meant that the patients who had the flu were really left in the care of nurses. And nurses played a very important role in responding to the pandemic in Canada. They provided supportive care for patients with the flu, but they also became very much involved in the public health response through promoting public health measures and education. And in fact, Alberta was very proactive about the role of nurses in public health. And as early as 1916, 3 nurses had been hired specifically to work in public health, which was really quite forward-thinking for Canada at the time. Nationally, the nurses formed a very strong lobby, and they tried to petition the government to implement health reforms to address this crisis. And they actually represented a broader group, women's groups, that were really lobbying the government to form a federal Department of Health. Canada did not have one at this time. Various groups had been petitioning the government over the last 30 years to create one. And in early 1918, there was a women's war conference where these women's groups were really vocal in trying to get the Prime Minister at the time to create this federal Department of Health. Sadly, it fell on deaf ears until this report by Vincent Massey to the War Committee of Cabinet. And this report, prepared by Vincent Massey in October of 1918, so during the second wave, reported, and I quote, "The recent epidemic of Spanish influenza points to the need for a federal health authority. Throughout this crisis, there was no organization competent to handle the problem on a national scale. The control of the disease was necessarily left to local boards, many of them ill-informed, and all of them inevitably lacking in coordinated effort." So it was quite a scathing report of the government response. And then Massey goes on to state what could have been achieved if Canada had a federal Department of Health. So our response could have included issuing warnings, ensuring a uniform coordinated plan, guaranteeing that proper information was circulated, particularly relevant to science and evidence-based medicine, could have contributed to isolating the influenza and discovering preventative sera, and it could have monitored disease, compiled statistics, and tracked its spread across the country. Now, when I look at this, I see the 5 of the core pillars of a public health response today. We have planning and coordination. We have the importance of science and evidence-based medicine. We have isolating the pathogen and developing a vaccine, and we have surveillance. Now, in response to this, the government did decide to create the Federal Department of Health. It was created in 1919, and the first draft of Canada's pandemic plan was created in October of that year. So what did we learn from this pandemic in 1918? I think this was one of our first experiences with a disease of such a global scale, and particularly recognizing the impact of globalization in the context of the war and this massive movement of populations who are carrying disease to all of these far-flung places. There was also the recognition of the role of science in the public health response, so particularly with respect to germ theory and some of the approaches to try to prevent that human-to-human transmission. And politically, it created the need for pandemic preparedness, and that's what we saw coming out of the Federal Department of Health. So after 1918, there were two other flu pandemics in the 1900s, one in 1957 and one in 1968. But I want to fast forward 91 years to 2009 to a pandemic that I'm sure many of you will remember. So this pandemic affected, again, most of the countries around the world, but the number of cases were far fewer than what we saw in 1918. Tens of millions rather than hundreds of millions. We have 150,000 to about 600,000 estimated deaths. This is very different from what we saw with the 50 million from 1918. And in Canada, there were 428 deaths rather than 50,000, and 33,000 confirmed cases. Now, based on our past experiences with flu, which originated from exposure to birds, and most of the flus in the 1900s really started in Asia, it was a surprise when the 2009 flu turned out to be a swine flu that originated in Mexico. And Mexico started reporting the first cases of the flu in March of 2009. Then there were cases that emerged in California and Texas. And it said that once the virus got to JFK Airport, it went global. Now here in Canada, we started seeing cases in April of 2009. And in fact, when I was at the Provincial Lab for Public Health, I remember one of our very first cases of H1N1 in Alberta was in a laborer who worked on a pig farm in Alberta, but who had just returned from a trip to Mexico. And it was really confusing for the lab to try to tease apart, was this a pig virus that was already endemic in Canada that people were exposed to, or was it from travel to Mexico, and where did this all come from? We now know that this unusual strain was an H1N1 that's called a triple reassortant. And what that means is that this flu includes genes from a bird flu origin, human flu origin, and pig flu origin. And these viruses had been recombining in pigs probably over the decade before the 2009 pandemic. Pigs are a reservoir for flu viruses. They're kind of like a mixing vessel where different genes from viruses can mix and match. And because Mexico was very much involved in the pig trade, this was an ideal setting for these viruses to develop. And once they evolved the ability to infect humans, that's when we saw the pandemic of 2009. Now, this pandemic shared many similarities with the 1918 pandemic. It also came in waves. So these waves, again, they were not during our winter season. We saw them in the spring, and then we got a second wave in early fall of that year. But we also know that the strain that caused the 2009 pandemic is genetically related to the 1918 strain, so going back to that original strain. And we know this thanks to a very important scientific advance in a technique called genome sequencing. This is a technique that allows scientists in the lab to completely decode the genetic information of that virus and to really understand every aspect of its sequence, which helps us identify its origin. And with this technology, which was first really developed in the 1990s in the era of molecular biology, by 2009, this was becoming more routine. And with the 2009 strain, it was actually just a matter of days to weeks to discover the strain that caused this pandemic. And Canada played a very important role in discovering the 2009 strain. Dr. Frank Plummer, who was the scientific director of the National Microbiology Lab in Winnipeg, told me a few years ago that he remembers in early April of 2009, he was at a Winnipeg Jets game when he received an email from his counterpart in Mexico asking if his lab could help decode the sequence of this virus that was causing these outbreaks of flu in Mexico City. And the very next day, he said the president of Mexico offered his personal plane to fly samples from Mexico City to Winnipeg to start this process of whole genome sequencing. And literally within days to a week, they had the sequence for this virus. And at the same time, the CDC in Atlanta was using the same approach to sequence the virus from their cases in California and in Texas. And of course, it turned out to be the exact same strain, which had originated in Mexico. So it took a matter of weeks to discover the sequence of the 2009 virus, but in fact, it took 87 years to discover the genetic code of the 1918 strain. So if you recall, in 1918, we didn't really know what viruses were. It wasn't until 1931 that the flu virus was actually discovered and could be cultured in the lab. And then only in the 1950s did they develop an animal model to be able to study the virus in the lab and understand how it could cause so much disease. So in the 1950s, there was a really keen interest to try to recover samples of the virus from people who died in 1918 and try to wake up this virus and put it into animals and be able to understand more about why it caused so much death. And one of the scientists is Dr. Johann Holton from the University of Iowa, who learned about a community in Breivik Mission, Alaska, which was very tragically decimated, almost decimated. I think 78 out of 80 people in this community died from the flu in 1918. But because of their location so far north, the bodies were buried in the permafrost, which created better conditions to try to preserve the virus over all this time. So Dr. Holton's team traveled up to Breivik Mission in Alaska. They obtained permission to exhume the bodies, and they collected some tissue samples from the lungs of those people who died. They brought them back to their lab in the US, and sadly, they could not wake up this virus. It just wasn't preserved well enough to support replication in the lab. Then in the late 1990s, when this sequencing technique really evolved, now there was a new opportunity to try to decode the 1918 strain. Because now scientists didn't need to wake up the virus and have it grow. They just needed to get a little bit of its genetic sequence or genetic information to be able to run it through the tests in the lab and figure out what it was. So it didn't need to be alive, it just needed to be intact. And Dr. Holton, by this time, had retired, but he decided to go back up to Alaska on his own dime. And again, he got permission to exhume the bodies, and from one particular person, he was able to get a tissue sample that he then sent to his colleagues who were doing this sequencing method in the lab. And by 2005, they were able to report the genomic sequence of the 1918 strain. And when they looked at this sequence, they found that it was also an H1N1 virus, and it actually shared a number of genes with that original strain back from 1918. So there are many similarities with the 1918 and 2009 flu, but there are also some important differences. We know that the virus in 2009 was inherently less transmissible than the one in 1918. This reproduction number is now about 1.5, so fewer people would get infected with every exposure. And we also saw from the mortality data that the mortality was much lower in 2009 compared to 1918. This could be due to a number of things, particularly having antibiotics to treat those secondary bacterial infections. Also, in general, just having better health systems would have contributed. So the public health response in 2009 included some of the tried and true measures from 1918, limiting public exposure. There were some school closures here and so on, as well as promoting hand washing and hygiene. Many of you may remember this is when all the hand sanitizers appeared in the hospital across the street. But we were also able to respond in a different way thanks to these advances in scientific method. So in particular, having that genome sequence of the 2009 virus led to a number of other ways that we could respond to the pandemic that were not available in 1918. And in particular, the development of diagnostics. So once we had the sequence from the National Microbiology Lab and the CDC, we could use that information to very quickly develop diagnostic tests that would target the H1N1 virus away from any other respiratory infection that could be circulating in the population. And this was done here by Dr. Lily Pang and her team at the Prov Lab. Within days, they had a diagnostic test specific for this virus. And this test was used on an incredible scale to try to figure out who in the population was actually infected with this virus and who was not. At one point in the lab, we were testing almost 1,000 patient samples every day. So having these diagnostics were really valuable to be able to see of those people with an acute infection, who really has this pandemic strain and who doesn't. But these tests can also be used in the community for surveillance and to try to track this virus and see where is it going, which communities are affected, how efficient is our public health response at curbing this pandemic. But the sequence also led to another important development, which was that of a vaccine. So once the sequence again was available, the WHO issued a call to vaccine manufacturers to develop a vaccine against H1N1 as quickly as possible. Now this took 4 months, which many would argue is far too long, but with the technology of the day, that was the fastest that could be achieved. So this vaccine was actually available during the second wave of the pandemic that occurred in the fall of 2009. Now another important tool was that we already had several vaccines against bacterial infections that would have killed people in 1918. So in terms of vaccines, we had this rapid development of the H1N1 vaccine in combination with some of the vaccines that we already had for the bacteria. So looking ahead, what will cause the next pandemic? What will it be? I think it's probably likely that it will be a new strain of influenza. We're always seeing new strains emerging, and the surveillance at a global scale is really keeping an eye on what's coming up where. But remember that it may not be an influenza. It could be something entirely different. It could be an emerging pathogen, like we saw with HIV or Ebola, something maybe that infects animals and then crosses that species barrier to be able to infect humans. But it could also be a pathogen that we're very familiar with and that we can treat and we really don't think very much about, but that all of a sudden develops resistance to the drugs that we use to treat it. And a particular concern is the development of bacteria that are resistant to antibiotics. We may be facing a crisis with that. And in the field of malaria, we're now facing parasites that are resistant to the frontline drugs that we use to treat that infection. This resistance emerged in Southeast Asia, and we're now tracking it, and the big fear is that it will spread to sub-Saharan Africa and compromise all the gains that we've made in trying to control malaria. So whatever this pathogen is, how are we going to respond? What does our response need to look like? So I would suggest that obviously the first thing is we need to know what we're dealing with. We need to use these sequencing technologies, which are constantly evolving, to be able to identify the bug. Is it a bacteria? Is it a virus? Is it a parasite? And we saw this very recently with the epidemics with Zika and with Ebola, that this sequencing approach was able to very quickly identify the pathogen, but then also know more about the strain. So that tells us where it came from and that we can use that information to track it. Once we have that sequence, we then need to develop diagnostics. So we know who in the population is infected with this pathogen. And that really requires having strong research and development capacity, particularly at the level of the public health lab. Next, we need to understand how this pathogen is transmitted, and then to tailor the public health interventions according to the transmission route. So some examples could be infection prevention and control measures to protect healthcare workers. It can include travel advisories like we saw for pregnant women traveling to South America during the Zika epidemic. And it also could include cultural considerations. For example, the burial practices in West Africa that were a huge concern for transmitting the virus during the epidemic in 2014 to 2016. Next, we need to know who is at greatest risk of dying from this disease. As we saw in 1918, we had this age group of 28-year-olds who were dying from the flu that no one would have ever predicted. So the way to find who is at greatest risk is to look at the severe cases. And that means working with the various clinical groups to identify those who are most susceptible to this pathogen. So with the flu, that means working with clinical care doctors. With Zika, that meant working with obstetricians to prevent pregnant women from being infected. Then politically, we need to implement a response plan. Most jurisdictions now have a pandemic response plan. This needs to be activated, creating a chain reaction where everyone knows what they're going to do and how they're going to communicate that plan. This also involves data sharing. I think this is one area that can be strengthened, particularly when you need to respond quickly at the municipal, provincial, national, and international level. We need to share case information, what strains, who's being affected, and so on. And of course, we need to initiate surveillance. Now, ideally, you'd want to have a surveillance program in place before the pandemic, and that's what we have for flu. In Canada, we have something called Flu Watch, where you can go online and you can see the number of cases of the flu in the country week by week. And epidemiologists are tracking that surveillance system to look for when does it go above background? When are we starting to see more cases or in a different population than we've seen before? Now, obviously, if it's an emerging pathogen, we can't have surveillance ahead of time. But once we're in the midst of a pandemic and we have the tools to be able to track this infection, we then need to be able to monitor it. That could be border screening. That could be going into the community and testing people for this pathogen. Not everyone will get sick. And we saw that even in 1918. Many people were asymptomatic. But those are the people who are still contributing to transmission. Ultimately, we need to develop and quickly implement a vaccine. And this involves a few different steps. First of all, you need the vaccine. You need to assess whether it is safe. So you have to do clinical trials. And then you need to be able to immunize people very quickly. So with the flu, there is really an ongoing quest for a universal flu vaccine. Now, as I mentioned before, the flu virus is a bit of a moving target. Every year it's changing. It's mixing, it's matching, it's changing its code. So it's been very challenging for scientists to be able to develop one vaccine that will protect you not only against all of the seasonal flu, but whatever new flu strain could be coming out of the woodwork. Now, once you have the vaccine, you then need to know if it's safe. You need to do some rapid clinical trials before you can immunize massive populations. And here, an example of a success story was with the last Ebola epidemic, where the lab in Winnipeg had actually developed an Ebola vaccine, and they were able to very quickly move to clinical trials in West Africa at the very end of the epidemic in order to test whether this vaccine was safe and could protect contacts of people with the Ebola virus. An example of where we can do massive immunization campaigns, there's one from last year in Bangladesh where the WHO was very concerned that there would be a cholera epidemic in the Rohingya refugee camps. And they ordered a mass immunization campaign in this population, and within just 6 days, they were able to immunize over 700,000 people. So we have the tools, we have the capacity to do this, but we always need to be able to mobilize people very quickly into action. So are we ready to face this next pandemic? So I would advocate that we need to maintain research momentum. And I think this includes studying pathogens that we may not be exposed to at home. These could be some of the more exotic pathogens like Ebola. But if we don't understand the diversity in the pathogens, we'll never be prepared for something new that comes our way. We stand to learn a lot by understanding all of this diversity. We also can't just focus on what's happening in the human population. Our interaction with animals is growing, whether that's through our food chain and how we interact with the environment. We need to undertake what's called a One Health approach, which incorporates surveillance of disease in the human population, the animal population, and the environment. So we need to be mindful of what's happening in the world around us. We need to develop the public health tools to be able to launch a rapid response to a pandemic. This includes having platform technologies to rapidly be able to develop diagnostics, vaccines, new antiviral drugs, whatever it is we need to be able to curb the transmission of this pandemic. And finally, I would argue that we need to support capacity building. We need capacity building at home in terms of surge capacity, how to mobilize people to respond. But I would also argue that we need to ensure that we can enhance capacity building in developing countries. Often it's in the weaker health systems where a new pathogen can gain a foothold and can go unnoticed, and then with globalization, pathogens can spread around the world in a matter of days or possibly with one flight on an airplane. So by supporting strengthening of health systems in these fragile communities, particularly in war-torn areas, I think this is a very important focus for us in terms of protecting the global population from the next pandemic. With that, I'd like to thank a number of my colleagues who've contributed information for this talk and shared stories, particularly Dr. Dennis Shanks, who's the director of the Army Malaria Institute in Brisbane, and who also happens to be an aficionado on the 1918 flu. My colleagues at the Prov Lab, Dr. Lily Pang, Linda Chewy, and Dr. Graham Tipples, and Dr. Yuta Prixitis and Dr. Stan Houston from the U of A. And with that, I'd like to thank you all and take any questions.
Thank you. Thank you, Stephanie, again for that very informative talk, not only with the benefit of the 100 years of retrospective view, but also with the future thinking of what should be doing in preparing for something like that if it happens again. So I'm sure many of you in the audience will have questions. So if you do have, put your hand up and somebody will bring a microphone. And those who are joining by distance, please type your comments on the text box that is available to you, and somebody here will read that out loud as well.
Hi, I was just wondering if there was any correlation between the amount of cases of influenza in 1918 and how strictly the countries imposed rationing on their people.
Do you mean rationing in terms of the restrictions and movement and so on? Or?
Rationing is in restrictions on diet.
Oh,
and
on
just general
diet.
nutrition.
Oh, that's an interesting question. I don't know. Let's start.
I was just wondering if there were any differences in mortality between the sexes in 1918, if maybe more of the healthier males were away at the war, and then the ones who remained were possibly more sickly.
Well, it seemed like everyone was equally affected. So you had the men in the trenches who were dying, but then at the second wave, you had all the women at home who were dying as well. So, and it didn't seem to be a specific gender bias. Even within different army troops, you'd have some that were more affected than others, and that's something they don't understand.
Great. Thanks, Stephanie. Fantastic. Love it. Presentation. Thanks for that. I think another important public health intervention, too, is something we don't like to talk about, but it's quarantine. And it's kind of interesting, you know, in the SARS outbreak that occurred primarily in China. The ability for us to control that was because of a political system that allowed the government to shut down an entire city like Beijing overnight. So whereas the Chinese government kind of hid the SARS outbreak from the rest of the world when they knew they had a problem, they were able to go into quarantine. I think in contrast to the Ebola, you may recall that nurse that came back from West Africa and now is in litigation because CDC wanted to quarantine her, but she's now litigating because her rights were violated. So it's a very sensitive issue, but something we do need to keep in mind as well. The most powerful act in the province of Alberta is the Public Health Act. And for quarantine purposes and severe things like that, we never like to talk about it, but what if, we do have something so serious that we do have to take the rights of people away to control. And that's a serious question for public health to deal with as well too, because it no longer becomes a patient right, it becomes a public health concern. So, comments on that?
Yeah, well, it's interesting when you look back at the way Canada responded to the 1918 pandemic. Their foremost response was actually quarantine, but it was a naval quarantine. So in the 1800s, when Canada was faced with various cholera pandemics, the response of the nation was to just keep the boats out. And actually, before the Federal Department of Health was created, the only body that was tasked with protecting the public health of Canadians was the quarantine, I forget what they're called, the quarantine officers. So on Gros-Îles, which is in eastern Canada, they were planning to stop any boats that might be carrying the flu, and yet it crossed the border from the United States over land. And that was really a turning point for Canada to recognize that we can't just keep everything out by boat. We need to be looking at other ways of trying to respond.
Other questions, comments? Thanks a lot for your great talk tonight, Stephanie. I have a related question or comment about political will. Mass immunizations really do seem to reduce the spread of the virus, but it isn't mandatory. So what would a public health initiative be in that regard?
Well, that's a great question and a controversial one. Thank you, Pat. Well, it's true. We don't have mandatory vaccination, and I don't think we have ever experienced a situation in a pandemic where we've implemented any kind of mandatory vaccination. We haven't had a vaccine in time. I do think it's something that we do need to consider. It would depend how good the vaccine is. So if it has very high protection, then you can certainly make a case for mandatory vaccination. If it's like our seasonal flu vaccine that may not be quite as effective, then I think there could be some public resistance to that.
Pandemic preparedness.
Yeah.
Thank you very much for a really interesting presentation. I wondered if you could just comment on the issue of crossover from animals, both wild and livestock, and domestic livestock, and how you approach the issue of surveillance and managing that input, if you like, to the human system.
Sure. That is a very challenging issue because of the sheer number of chickens and pigs that we interact with in different ways. I know that in Asia, they now have implemented surveillance in the poultry industry. So because many of these bird flus have originated from Asia, they're trying to kind of keep that at bay at the source, at least to try to identify new strains and possibly cull herds if they need to. In Mexico, it was quite interesting because they hadn't realized that the pigs were carrying these viruses, but a group of scientists went back and they screened pig populations all over the country, and now they can see with this sequencing that these viruses had been in the pigs for the last 10 years. So now the discussion is whether they can afford to have a more active surveillance program. But of course, the sheer scale of that would be very, very challenging.
The town in Alaska that had a very high death rate, that was presumably because the population was so isolated and didn't have any contact with the rest of the world. And yet it is contact with the rest of the world which spreads disease. So how do you maintain the correct balance between giving people some exposure but not the kind of exposure which will cause disease?
Yeah, that's a great question. Obviously, that's not something we can orchestrate. In the case of the Alaskan community, they think it was actually from exposure with miners. that brought the virus into their community. We know that some of these very remote populations they fared far worse than some of the more populated countries. You even saw a difference between urban and rural. So people living in urban areas fared better than people in rural areas. So we know that having some immunity to whatever pathogens, viruses, and so on are circulating does build up your protection, and there is that risk of being very isolated. I don't think there are that many communities left that would be so isolated at this time like what we saw in 1918.
Thanks, Dr. Yanow. That's really good. So my question is about clinical trials. And so I often hear about people who start trying to develop a vaccine, and it takes them years and years to get clinical trials set up and whatnot. And so when it comes to a pandemic, you see people developing vaccines really quick, getting the clinical trials done, and then just firing these things off. So my question is, in the case of a pandemic, do you still have the same checks and balances in terms of safety when going through all the developmental stages of a vaccine that you would normally see in day-to-day life?
Well, I think that all the safety checks have to be maintained, but I think the procedures are fast-tracked. So the approvals, the review of the vaccine, all of those steps would be fast-tracked. And with the Ebola, what they did is they brought in the vaccine through this ring vaccination. So not going in and immunizing the entire population, but any contacts of people who'd been exposed and sequentially trying to immunize people in that way. That way they can make sure as well that it's safe. And I think that's true for drugs as well. They can fast track some of the not fast tracking the approval. I think it's just more the bureaucracy that normally slows this down.
Hi, thank you very much for the presentation. I just have a few questions in regards to marketing. So my question would be, with the flu vaccine that comes out each year and having its efficacy in elderly and as well as in adults being at questionable rates, I was just wondering, how would you advertise that immunization is something that is necessary to the public? And the second question would be, has there been any examples of natural resistance through influenza throughout the world?
Yeah. Okay. So for the first question, I think the messaging around the vaccination for the seasonal flu is really about protecting those people who are immunocompromised. So by being vaccinated, you contribute to what's called herd immunity. So the more people get vaccinated, the more the protection will affect the general population. And when you have people who are immunocompromised, they're at such a high risk of mortality from these viruses. So even though you may not benefit personally, there is that community or public health benefit to those who are at greater risk. And you're asking about resistance. I know for the flu, there have been some reports of resistance to some of the antivirals that exist for the flu. You're talking about drug resistance, right? Yeah. So there have been some case reports of resistance.
Wonderful, thank you so much. Once again, join me in thanking Stephanie Yanow for
Thank you. I did my best.
Couple of housekeeping things. You got a survey when you entered the theater. If you take a minute to complete